the association of Hoover sign with the maximal expiratory to inspiratory pressure ratio in patients with COPD. This was a study that I worked on with Dr. Slocum and a few of my other colleagues, Dr. Maloney, Dr. Magera, Dr. Vincent, this past year. And we had the luxury of being published by CHEST in the Journal of COPD. I will say, just to start off, this isn't the most landmark study that's ever been published, but it is a good reminder that we can explore topics that we're interested in, and that data can be published and possibly provide further information to clinicians. So as mentioned, my name is Zach Anderson. I'm one of the third-year internal medicine residents here at Freeman. I did my medical school training in Kirksville, Missouri, with the picture on the right. And I wanted to include this slide because it feels like to me some of the Zoom PowerPoints are a little less personal. And so I wanted you guys to know a little bit about me as I shared this information. So I was born in LaGrange, Georgia, about an hour south of Atlanta, and my family still lives there. I went to the University of Georgia, go Dogs, back-to-back national champions. And then, as I said, I graduated from the Kirksville College of Osteopathic Medicine in Kirksville, Missouri, and have done my residency training here at Freeman. I had the wonderful opportunity to marry my wife 2 years ago. The picture to the left, she's an emergency medicine physician here. So if you see her, say hello. And then we're the lucky parents of 3 furry friends, Phineas, Neville, and our newest addition, Remus. As you can see in the picture to the right, they're not the best of friends, but man, they sure look good in a Christmas collar. And then the last slide about me, my family is probably the most important thing to me. The picture on the right is at my sister's wedding recently. I had the wonderful opportunity to be her officiant. And then the picture to the left, probably my second most favorite person in the world after my wife, my grandmother. Her name's Romanza. She's 89 years old. Getting into our topic today, I have no personal, financial, or commercial disclosures to report. And kind of an outline of what we'll go through today. We'll talk about some background information and literature review on the topic, our research objectives of our study, methods and data collection of our study, our findings, conclusions, next steps, and some acknowledgements. So there's really 4 major things that I think we all need to be on the same page at if we're discussing this topic. And I tried to keep the background information at varying levels for whoever may be present at this lecture. And so looking at pulmonary function testing, which was a real core part of our study, just to get some basics and lay down a foundation, this is typically consists of spirometry, lung volume measurements, and DLCO measurements. And these are the core values that pulmonologists use to evaluate and diagnose diseases of the chest. There are some ancillary studies you can include when obtaining pulmonary function testing, including maximal respiratory pressures, flow volume loops, and if you are concerned about asthma or other hypersensitivity diseases, you can do bronchoprovocation. Here at Freeman, we have the luxury of performing respiratory pressures on all of our patients. And so as we get into this study a little bit more, you'll see those measurements were key to our study, and it was very convenient that we obtained them here. When we talk about diseases of the chest, the most essential measures of pulmonary function testing are the FVC, the FEV1, and the FVC to FEV1 ratio. So the FVC is our forced vital capacity. Our FEV1 is the forced expiratory volume in 1 second, and then their ratio. And the image to the right actually shows an asthma type picture with reversibility with bronchodilator therapy. But as you can see here, all of those values we just talked about are presented and used for interpretation. So more on the respiratory pressure measurements. These are ancillary studies, as we mentioned, used in pulmonary function testing to evaluate respiratory muscle strength. And UpToDate cites the indication for these as unexplained decreases in vital capacity or respiratory muscle weakness. As mentioned, we obtain them here on most of our patients to provide some information, but they are used throughout the country. Some people use them more often than others. Their advantage is they're relatively easily obtained. It just adds one more step to pulmonary function testing, and they can be trended, especially in patients who have neuromuscular diseases, which cause diaphragm dysfunction. They can be trended and used to provide data points about how the patient's respiratory function is changing, improving, or worsening. Two measures we obtain when we look at respiratory pressures are the maximum inspiratory pressure and the maximum expiratory pressure. And so the MIP, or maximum inspiratory pressure, is the maximal pressure that can be produced by the patient trying to inhale at full exhalation. So you've exhaled all of your air and now you're trying to inhale with as much pressure as possible. It is represented by a negative airway pressure. And as you'll see later, we express these as absolute values. The maximum expiratory pressure, on the other hand, is the maximal pressure during forced expiration. And this is done at full inhalation. The advantages of these values: the MIP can measure the ability of the diaphragm and other respiratory muscles to generate inspiratory force, whereas the maximum expiratory pressure does not really incorporate the diaphragm, as we do not use that for exhalation, but instead looks at the chest wall mechanics, abdominal muscles, and other respiratory muscles and their ability to generate expiratory force. So looking at COPD, some things that I think we all need to know to be able to interpret this study. It's a progressive lung disease characterized by airflow obstruction, and typically, as we all know, presents with dyspnea, cough, and sputum production. These values have now changed, but previously it was diagnosed by an FEV to FVC ratio of less than 0.7. And then it was categorized by the severity of FEV1 decrease. If you've looked into pulmonary function testing recently, they've now moved on to Z-score type of categorization, but our study was made when the guidelines were still supporting the use of FEV1 as a percent, and so we will stick with that. And per the GOLD criteria, the organization, which essentially is the foundation of COPD care in this, really the globe, the categories are broken down based on FEV1, with mild or GOLD 1 stage being an FEV1 greater than or equal to 80%. GOLD 2, moderate COPD, an FEV1 of 50 to 80%. Severe GOLD 3, FEV1 of 30 to 50%. And then very severe GOLD 4, FEV1 less than 30%. In patients who have COPD, we know that there is evidence of diaphragm dysfunction, and this is really manifested in our findings we associate with COPD, things like flattening of the diaphragm, hyperinflation of the lung fields. And this is really important for our study as we are evaluating the function of the diaphragm. So in a normal patient, typically we're going to see the diaphragm contract downwards based off of its radius of curvature and its apposition at the zone of apposition. It has a large amount of connection with the lateral ribs. And so by contracting downward, you actually get an outward force applied to the lower lateral ribs. This creates a negative inspiratory pressure, which causes airflow into the lungs, filling the lungs and allowing for respiration. However, in patients with COPD, in which their diaphragm is now flattened, they've lost that zone of apposition as the diaphragm has flattened, the radius of curvature of muscular contraction no longer is downward, and it's actually medial. And so it contracts, causing inward traction of those lower lateral ribs. And this information here is extremely important to understand the entire really basis of our study, which is that in these patients, we're going to see something called a Hoover sign. And Hoover sign was first described in patients in 1920 by Charles Franklin Hoover. Dr. Hoover has multiple signs named after him, and so that's why this is specified as of pulmonary disease. And this is defined as paradoxical inspiratory retraction of the lower intercostal muscles, lower intercostal spaces due to traction of the lateral ribs caused by altered diaphragmatic contraction by a flattened diaphragm. So a lot of fancy words to describe what we just talked about. In normal patients, you get an outward movement of the lower lateral ribs with inspiration. In patients with the presence of Hoover's sign, you get an inward contraction of the lower lateral ribs with inspiration. This was a highly specific finding in obstructive airway disease, and actually has been described as being 58% sensitive and 86% specific for obstructive airway disease in previous studies. It is seen with increasing frequency in higher gold stages of COPD, with 36% in that moderate stage we talked about, 43% in the severe stage, and 76% in the very severe stage. And then why is this sign important to discover? Well, its presence is associated with higher dyspnea symptoms, higher exacerbation frequency, and increased frequency of hospitalizations and emergency department visits. This is a visual representation of the Hoover sign, and to be honest, it was really hard to identify a picture which adequately represents this. The palpatory findings are pretty prominent when you place your hands on a patient and feel it, especially the first time. But as you see in the pictures here, A is with inspiration and B is with expiration. A, you see the lower intercostal spaces actually having traction inward. They are showing evidence of retraction. And then in comparison to the expiratory phase, you can kind of squint a little bit and see that maybe that lateral rib margin is more medial than in expiration, which is a paradoxical motion. So kind of pulling this together, and the last point that I think we all need to be aware of is that with our understanding of the MEP to MIP ratio representing the function of the respiratory muscles, in theory, this could be utilized to evaluate for diaphragm dysfunction. And so previously, respiratory pressure measurements have been used to evaluate diaphragm function. This was done by Koo et al. In 2017. And they looked at it as a non-invasive screening test for diaphragm paralysis and neuromuscular respiratory disease. And why is this important? Well, when we are evaluating diaphragm dysfunction, there's a variety of testing modalities which are available, but many of them are invasive. For example, or require radiation. You have fluoroscopy, you have direct EMG, you have chest radiographs. One that's not really invasive, it would be ultrasound guided diaphragm evaluation. And this is becoming much more prominent and actually is an important point, as I believe it would be our next step in evaluating this study. And that's why it's included here as a subpoint. So looking at the literature that was available to us prior to our study, really we didn't see a ton of prior studies linking MEP to MIP ratio directly to diaphragm dysfunction. There were a few out there. So we just looked at what has been done before. And in patients with Hoover's sign, there's been a phenotype described previously in which they had older age, higher BMI, and more severe airflow obstruction. Prevalence, as we discussed, does increase with severity of obstructive airway disease. And then despite a theoretical relationship, as we've talked about, the hyperinflated lungs, there has not been evidence to support that Hoover's sign itself is related to a higher degree of hyperinflation over an individual who has the same severity of COPD, but no Hoover's sign. And then, as I talked about on our last slide, Koo et al. Did previously evaluate the MEP to MIP ratio, and they kind of set some normals. This was a relatively small study, but it was the first of its kind. And they found that an MEP to MIP ratio of about 1.5 was normal. A patient with unilateral diaphragm paralysis could be expected to have an MEP to MIP of around 2.1, and an individual with bilateral diaphragm paralysis would be expected to have an MEP to MIP of about 4.3. So as I said in the last slide, we really didn't see any prior studies which evaluated the association of the Hoover sign in COPD with a change in the MEP to MIP ratio. But based on our understanding of everything we've just talked about, patients with COPD have altered diaphragm biomechanics. We wondered, is this related to the presence or absence of a Hoover sign? And if so, would we see that diaphragm dysfunction manifest on changes to the MEP to MIP ratio? And that really was the foundation for our study. Would we observe a statistically significant difference in that ratio in patients who have a Hoover sign or do not? So our research objectives was just that. And in formal language, we wanted to determine whether Hoover's sign of pulmonary disease is associated with a change in the MEP to MIP ratio in patients with advanced COPD. A more secondary outcome of our study, we wanted to determine whether this sign was associated with any baseline characteristics. Would our study support the previous findings of higher or older age, higher BMI, more severe disease representative of manifesting that Hoover sign? And would we be able to see any variables on PFT testing that could allow us to say, yes, this patient has a Hoover sign or not? So our design, we performed an observational prospective single center cohort study that took place at the Freeman Lung Institute, which is an outpatient pulmonology clinic. Our study was completed from October 2021 through May 2022. And all PFTs and respiratory pressures were obtained by trained respiratory therapy technicians, and they were blinded to all other data. Hoover sign examinations, on the other hand, were performed by Freeman internal medicine residents, and all of the examiners had been trained previously in the identification of the Hoover sign by Dr. Philip Slocum, and we were all blinded to the PFT and respiratory pressure data when performing these examinations. And our supervisor, Dr. Philip Slocum, an early thank you, and he'll be thanked again. Our inclusion criteria, we wanted to include anyone who was over 18 years old, and then they must have completed pulmonary function testing and respiratory pressure measurements at the Freeman Lung Institute during our defined study period. All of the patients we were evaluating needed to have a known diagnosis of COPD, and we opted to choose patients who had more severe COPD, stage 3 and 4, or an FEV at max of 50%, because of what we talked about earlier, that the Hoover sign is present in patients with more severe disease. So we wanted to kind of manipulate our population to have a higher proportion of Hoover sign, because that's what we were studying. Our exclusion criteria, any patient who met the inclusion criteria but didn't want to undergo the physical exam, they were excluded. And really that came down to a lot of times transportation, availability, et cetera. And then if a patient had signs of an acute exacerbation of COPD during either phase of testing, they were excluded from our study. So our methods, our PFTs were obtained at the Freeman Lung Institute. And as previously mentioned, they were screened for evidence of GOLD 3 and 4 COPD. This screening was done utilizing just visual screening of all the documents, which were then placed into an Excel spreadsheet. Patients who met the predefined inclusion criteria were then contacted by one of the examiners or other representatives and offered to schedule a Hoover sign. These exams took place on most Fridays during the study period at the Freeman Lung Institute afternoon when patients were not being seen. And then 2 residents examined each patient who participated for the presence of a Hoover sign. They were examined on the same day by 2 separate residents. Both residents were not performing the exam at the same time. No information was shared during between examinations, and the patient was not informed of whether each examiner felt like they had a Hoover sign until after both examinations were completed. And then these were all performed in the seated position. I did not include a picture here, but our typical method for evaluation was to place our hands on the patient's lateral lower ribs and allow them to go through their normal respiratory cycle. Some individuals we would ask to take a larger breath or a smaller breath based on how they were breathing. Occasionally, we did have to ask patients to lift up their shirt to evaluate their lower ribs, as sometimes having a large body habitus did preclude us from really good examination, but we would do it until we made sure we were confident. So what did we find in this study? So we screened over 1,000 pulmonary function tests during our study period, and we found that about 161 of our patients who had been screened during that period met our inclusion criteria. Of those 161 patients, 71 agreed to undergo Hoover sign examinations. And so that's about 44.1% yield of our patients who would have met the study inclusion criteria. Of those 71 patients, 41 were males, representing 57.7% male population. 30 were females, or 42.3%. And the median age was around 67 years old. The range was 44 to 91 years old. And then of those 71 patients who met inclusion criteria, 35 of those individuals ended up having evidence of the Hoover sign. And so you can see with our diagram here, here's our breakdown of patients: 161 to 71, and then 35 with the Hoover sign and 36 without the Hoover sign. So looking at our statistics, what measures did we use? And just kind of an aside, all the time when you're evaluating research, you should make sure you understand how they calculated their statistics, what thresholds they used, because you can really manipulate data. We tried our best not to here, and so our data was not normally distributed, and so we had to use the median and range as a measure of central tendency, and then to determine the statistical significance of our variables, we used the Mann-Whitney-U test and the chi-squared test. We did set a p-value threshold of 0.05, as most studies do. And then we did have to express our MIP and MEP to MIP ratio as an absolute value, because as we talked about previously, the MIP is a negative value, and it did make it somewhat difficult to utilize those numbers in calculations, but it does not change what it means. So here is our data we obtained from our 71 patients who were included in our study. As you see here, these are our baseline characteristics, and characteristics are seen on the left-hand side of the picture. The second column really is our total. Third column are patients who had no Hoover sign, and then our fourth column, the patients who had a Hoover sign, and then our p-values. And so looking at our groups, there's actually pretty good, not a ton of significant variation of age, BMI, and we had very similar values for our proportion of male patients and female patients. I think this is very important because, as we've talked about previously, the presence of a Hoover sign is associated with these variables. And so if we had seen that, it would be hard to interpret whether or not the Hoover sign itself was altering the MEP to MIP ratio, or it could be their body habitus or their age. And so by having these values be similar in each group, we actually can say with more certainty that the MEP to MIP variation may be due just to the presence or absence of Hoover sign. We have a lot of variables here, and I want you to focus on the ones in red. And I think those are really the key findings of our study here. Looking at the MEP to MIP ratio itself, the last row, our total patient population had an average or a median MEP to MIP of 1.49. Our patients who had no Hoover sign on examination had an MEP to MIP of 1.16. And then our Hoover sign present patients had an MEP to MIP of 1.88. And that was statistically significant with less than 0.01 p-value. Our MIP value was lower in our study group, the Hoover sign present group, which really, when you look at it here, was driving our lower MEP to MIP ratio. And then we did present a new finding that there is an alteration in the RV to TLC ratio, with our Hoover sign patients having an RV to TLC ratio of 65 versus our Hoover sign absent having RV to TLC ratio of 59.5. And that was statistically significant as well, with a p-value of 0.014. Another way to represent our data is this box and whisker plot. And for those who love research, they will know that this is not the most useful plot in the world, but I think it shares the point here. The horizontal lines within the box represent the median. And as you can see, our median of patients who had a Hoover sign is outside the range of the box and whisker plot of the no Hoover sign, which does imply some these are real values, you can trust it, and statistically significant. So what do we conclude from this study? Really, regarding our primary outcome, as you saw on the table, we did discover that patients with advanced COPD and Hoover sign present on exam had an increased MEP to MIP ratio compared to those without Hoover sign, with those with Hoover sign having that MEP to MIP of 1.88 versus those without having 1.16. In my personal opinion, and based on our evaluation, we believe that this supports the use of the MEP to MIP ratio as a marker of the presence or absence of Hoover sign, as well as a marker of diaphragm dysfunction. I think this is an adjunct to that Koo et al. Study that had been done in 2017, and now adds a new category to that. It's no longer normal unilateral or bilateral paralysis. In between that normal and unilateral diaphragm paralysis group, there's a diaphragm dysfunction group that does have an altered MEP to MIP ratio, but may not have overt paralysis. As mentioned previously, this was really driven by our lower MIP. One thing to caution, our values of MIP in both groups were heterogeneous with wide ranges, and it does make it somewhat difficult to use that alone to diagnose diaphragm dysfunction. But when used in conjunction with our MEP to MIP ratio, it provides you a good understanding of what the patient's diaphragm is doing. We did present a new finding, a novel finding which had not been discussed in the literature previously, in which our patients with Hoover sign did demonstrate an increased RV to TLC ratio with 65.0% ratio in patients with Hoover sign and 59.5% in those without. And what this means is that there may be a component of air trapping, which is playing a role in the development of diaphragm dysfunction. In conjunction with what we talked about previously, in that hyperinflation itself is not really associated with the Hoover sign. Maybe air trapping is what just makes people develop the diaphragm dysfunction in Hoover sign. I think that will need to be studied further in the future. One thing of somewhat interest was our MEP in those with Hoover sign was elevated more significantly than those without. However, it was not statistically significant. This is somewhat of an unexpected finding, as people with severe obstructive airway disease have classically been associated with a lower MEP. I do wonder, though, if someone is having to utilize their abdominal muscles quite a bit to exhale in the setting of an obstructive airway disease, could their pressures be higher? I honestly don't know, and I think that it was a little bit of an interesting finding. Another value that wasn't statistically significant, but I think is an important marker, is that our patients with Hoover's sign had a decreased inspiratory capacity to total lung capacity ratio. This is the IC to TLC ratio is a known independent predictor of all cause and respiratory mortality in those with severe COPD. And so it's the fact that it's lower in our group with Hoover's sign makes me wonder, do these patients actually have increased risk of decompensation? Sadly, this was not statistically significant with a p-value of 0.072. But I do think it is, a correlation, which the understanding of Hoover's sign having higher frequency of exacerbations, higher presentation to the ED, would imply to me that there may be an association with risk of decompensation. Looking at its comparison to previous studies, so as I mentioned, this really puts diaphragm dysfunction and the Hoover sign kind of in between normal and paralysis. And I think this is a really interesting concept and something that I wasn't expecting us to define, but I think it does require more study in the future of, do these patients actually have true diaphragm dysfunction? I would say our study supports yes, and it does fall somewhere in between normal and true unilateral paralysis. One thing that I will mention is, as you guys saw previously, our normal our normal was quite a bit lower than Ku et al.'s lower of normal of 1.5 hours was 1.16. I'm not certain exactly what drove these findings. And honestly, it may just have to do with our patient population. Additionally, we did focus on slightly different populations than Ku et al. did. Ku et al. Screened out COPD, whereas we kept our COPD patients at the forefront. And so you do wonder if that played a role. Similar to a prior study by Garcia Pachon et al., our Hoover sign was found in 49.2% of individuals with gold stage COPD 3 or 4. And as we mentioned previously, around 43% of patients have been shown previously to have Hoover sign in stage 3, and around 76% in stage 4. So we're right in the middle of that. Congruent with previous studies, our Hoover sign was not associated with hyperinflation. There was no association with just a baseline increased total lung capacity in our study, which I think, again, is interesting. We often cite hyperinflation as a key component to the findings we see, but maybe it's not the case in Hoover sign. Maybe it has more to do with that air trapping that we found with the RV to TLC ratio increase. And then, contrary to previous studies, our Hoover sign group was not found to have a statistically significant older age or higher BMI. And as I mentioned, I really believe this actually strengthens our study. What were some limitations of our study? Well, it was a single center study. And so we're going to have selection bias. Our patient population is going to be different than other patient populations in this country. And so you really have to evaluate what your proportion of patients was with different characteristics to truly utilize this data to apply it to your patients. But it doesn't mean that it's not valid. Our testing was done in the outpatient only clinic setting. So all of our patients were stable. They were not in an acute exacerbation. And so it's hard to know whether this data would stand up in that setting, in hospitalized patients, in patients with acute exacerbations. We believe that it can likely be applied to any patient in the outpatient setting, but we would need to study further in the inpatient setting to apply our thoughts to that. We did perform a qualitative evaluation. All of our Hoover signs examinations were done with palpatory skills. And so there is area to improve that. If we would have had a quantitative device, such as a diaphragm belt monitor or ultrasound guidance for really delineate whether or not what we were feeling was true presence of a Hoover sign, that would have been great, but we didn't have that ability. But our kappa statistic was 0.8, which really shows that our inter-rater reliability and agreement was quite good and really could be labeled substantial to almost perfect in inter-rater reliability. We did not exclude patients who had previously participated in pulmonary rehabilitation, and we didn't know it at the beginning of the study, but it turned out that interestingly, some of our patients who had no Hoover sign had been to pulmonary rehabilitation previously. So we're not certain what impact that played, but it did pose the question, does pulmonary rehabilitation cause improved diaphragm function and restoration of normal diaphragm movement and loss of a Hoover sign? We did not even think to exclude that at the beginning of our study, so it was kind of hard to plan for, but looking back, hindsight's always 20/20. So what are the clinical implications of this study? Well, at its base, we can detect this sign with good accuracy, equivalent to prior studies. And honestly, we can use this sign to help us understand where our patients are at. We can use it as a marker for suspected diaphragm dysfunction, the presence of a Hoover sign, and then we can utilize pulmonary function testing to correlate whether or not our physical exam findings are really there by looking at the MEP to MIP ratio. And if, around that 1.88 range may support the presence of a Hoover sign in the right person. And then some next steps, where do we want to take this? As I mentioned, some of our patients had previously been in pulmonary rehab. And so I do wonder, could there be some improvement in diaphragm function in those patients? Could you see Hoover sign be present and then send someone to pulmonary rehabilitation and their diaphragm function improves and they no longer have that sign? I do not know, but that is something that I have in my mind and would like to explore. We need to further validate our results using quantitative evaluation like we talked about. I think that would be ideal. We just did not have the technology or ability to purchase that technology. And then we need to look more at what role does air trapping play in diaphragm dysfunction in patients with COPD. Just to wrap everything up, I'd really like to acknowledge Dr. Slocum for supervising, being the primary investigator on this study. Without him, everyone in this list would not be where they are today, and we're just really grateful for him. Thanks to Dr. Maloney, a hospitalist at the University of Iowa and one of our prior residents, Dr. Ashley Vincent, and Dr. Adam Magera. We couldn't have gotten it done without you guys, and really just appreciate all your work. And then thanks to the respiratory therapists and the Freeman Lung Institute office staff, truly dedicated a lot of time to us and helping us wade through this and waiting on us after hours and locking up doors and cleaning up our mess. Just really, really thankful for everyone. So here's my references. You can access this study online with the same title. There are two separate links, one with CHEST and one with Journal of COPD. So feel free to read it on your own time if you're interested. And then thank you so much for coming today. If you have any questions whatsoever, I'd be happy to answer them or try to work through them with you. Thank you, Dr. Steele. I would say that the place I see this being used in the emergency department would be if you are going to perform a physical exam, why not take a look at their lower rib motion? And I would have a higher or a lower threshold to really be aggressive in patients with the presence of a Hoover sign. I think we've shown that with our study, there's some diaphragm dysfunction, and previous studies have shown that these patients have increased risk for decompensation, but I did not, I don't know that the MEP to MIP ratio is going to be super helpful for you, but really just the physical exam presence, and if it's there, have a little bit more concern for your patients. Thank you so much for your question. And then I got asked in the chat too, did I use the new Z-score for PFTs when analyzing and comparing? We did not use the new Z-score. I think it would be a fun adjunct to our study. Sadly, at the time of our study's completion, the Freeman Lung Institute was not reporting those Z-scores, so we were unable to evaluate those. But I would like to see how that pans out. Also asked in the chat, any opportunity for an extension of this study with future IM residents? I think absolutely. We still have the entire PFT database we utilized for this study, so that there's a lot of information there to be gained, whether or not it's a branch of this study or not. Additionally, I think that the next steps I talked about, which would be, ultrasounding the diaphragm to confirm our findings, or utilizing a belt-based diaphragm monitor, that would be a great next step. The research behind Hoover's sign and its real quantitative nature is kind of sparse, and so we're one of the few studies to add to that. I think that another study would be really great would be the pulmonary rehab. Take the group of patients we identified with Hoover's sign, put them through pulmonary rehab for a year, and see if they still have the presence of a Hoover's sign at that year mark. I think that would be an incredible follow-up study. And then also asked in the chat, for the Hoover's sign, did both examining physicians have to find the sign, or was one sufficient? And to answer that question, to be labeled as a true yes in our study, both physicians had to find the presence of a Hoover's sign. If the patient, if the findings disagreed, they were listed as no. So there is a little room for some changes in our data based off that. But I don't think that it would change our statistical significance. I believe there were only a total of 3 patients that we didn't agree on. And that would be why our kappa statistic was so high. Yeah, that's exactly why. So the question in the chat was, is there a correlation between Hoover's sign finding and GOLD criteria? And yes, that's exactly true. So their GOLD criteria, as they increase, your severity of airway obstruction is higher. And so they have found that Hoover's sign is present in more patients who have higher stages of COPD. And so we did want to choose our higher stages of COPD, so we would have to screen fewer people to find more Hoover's signs. So we wanted a high proportion of Hoover's sign in our population, as high as we possibly could. And so by screening only, or by evaluating only stage 3 and 4 COPD patients, we had at baseline, probably around 40% of those patients were going to have Hoover's sign, which would allow us to actually even correlate it to an MEP to MIP ratio. I would like to see is there any correlation between MEP to MIP and presence of Hoover sign in patients who have it, who aren't in those groups? I think that would further strengthen our study. But yes, that's exactly why we purposely tried to exclude patients who were less severe, so we would have more Hoover signs. All righty. Well, thank you all again. I really appreciate all your interaction with the questions and everything. It means a lot. It was a pleasure spending time with you all today, and I hope you have a great rest of your day and rest of your week. If you have any more questions, feel free to email me at the email below.